Hi, everyone. All right. Hi, everyone. It's Jayla. I use she, her pronouns. I know a lot of you are familiar faces, but welcome to all of the people that are new into this space today. We have our second career talk of 2024, and it is titled Compassionate Care Supporting LGBTQAI plus Patients in Oncology. And so welcome to everyone that is here. We would love to learn a little bit more about you and why you have come to this space today. I think one of the beautiful things about curating these specific talks and these spaces is that we're all kind of aligned in some way, shape, or fashion. And so if you all would go ahead and drop your name, pronouns, and maybe a little bit of a fun fact in the chat if you feel so called to do so. But we're going to get right into our scheduled program. And our conversation. So, like I said, my name is Jayla Burton. I go by she, her pronouns, and I'm the project manager of the Cancer Leaders Like Us program. I also have Shai with us today. Shai, if you want to go ahead and introduce yourself.
Yeah, hi, my name's Shai Seelot. I go by she, they, and I'm the senior project associate here on CLE.
Yes. And then we also have Dr. Andrew Martella, who is here today with us as well. And you all will get a chance to learn a little bit more about him as he is our guest for today. And but go ahead and say hello so people can see who you are.
Hi, everyone. I'm Dr. Andrew Martella. I'm one of the clinical assistant professors at Stanford. I go by the pronouns he, him, and I'm a cisgender gay male.
Yes. Awesome. Thank you so much. And so we'll get a little bit into that conversation a little bit later. But before we dive into that, I wanted to give folks kind of an overview of the network and the work that we do prior to like diving a little bit deeper. So the National LGBTQ, or actually we just changed our name or we're in the process of doing that. And so if you hear me saying different things, it's me unlearning, reprogramming, and all that fun stuff. But so the network works to improve the lives of LGBT cancer survivors and those at risk through education, training, and advocacy. We do a lot of education with providers. We educate patients, people that are affected by a lot of these intersecting identities and what that means when it comes to cancer. We do trainings for providers as well. We have a wonderful training that is available to any and everyone called Welcoming Spaces that can be found on our website. And we also do a lot of advocacy work as well, primarily like in the tobacco space, and working to make sure that we have policies that are protecting us and conquering those like preventative measures when it comes to what makes our community more at risk for developing cancer and other health harms. You can go ahead to the next slide. So within the network, we have a program called Cancer Leaders Like Us. Cancer Leaders Like Us we're currently in our second year of the program. This is super exciting because this is I believe we've done this will be our 8th career talk series. And so each time we have like new folks coming in, we're conquering different subject matters, like meeting different people. But basically, if you didn't know, outside of our career talk series, we do have other programming within Cancer Leaders Like Us. In addition to our career talks, we also have skill building programming, and this is programming primarily directed to and pulls in and builds community with LGBTQIA plus and or BIPOC emerging leaders that are interested in health as a profession, and we specifically want to expose folks to areas within the cancer space that are potential career opportunities, or even if you are interested in research and want to kind of explore some of the different avenues within this field, that is what this space is for. So I would say that not everyone that is in the Cancer Leaders Like Us space is currently right now working in at the intersect of cancer, but we know that cancer is a lot of things, right? It's a political issue. It is preventative. It's a navigation of care type of subject as well. So pretty much we do a lot within that. And so we also have different networking opportunities. And we also have, this past year, we launched an internship program where we have like a cohort of interns that have been placed with different host organizations nationwide and that are working to address like different health equity issues within that. So that kind of expands our network, our mission, and our values, like more on a broader scale. And at the end of our talk, I'll tell you all a little bit more of how you could get engaged with us if you have not been engaged with us already. But I'll save that for last. And I would love to jump into the conversation portion of this meeting. You can go ahead and stop sharing your screen, Shy, and we could get to all the nitty gritty later. But I wanted to, before we hop into this conversation, wanted to welcome anyone and also say that we will have an opportunity for question and answer after we go through the conversation. But if anything comes up for you all while we're chatting, feel free to drop it in the chat. This is totally a safe and welcoming space, and we will definitely get to your questions at the end. But without further ado, I wanted to, I guess we could transition into our conversation now. Just wanted to say, so Dr. Martella, thank you so much for being here today and agreeing to come and chat with the Cancer Leaders Like Us community. I know that you have done some work with the network before, an interview with the network before, so it's super exciting to bring you in at this capacity and at this level. But I just wanted to maybe start off with like, I kind of always love asking folks what are their origin stories and how did they get to be in the position that they are now. So if you could explain a little bit about how you got to where you are and why you chose cancer as a field and then specifically radiation oncology.
Absolutely. And yeah, thank you for inviting me. I think the work that that you're doing is wonderful. So I'm really appreciate being here. My story of how I sort of got into cancer and radiation is very zigzagged and not a necessarily straightforward pathway. I think that's true for a lot of people. So I could start from the beginning, though. Essentially, when I was quite young, I had a very personal experience. Both my father and brother had Hodgkin's lymphoma, which is a type of cancer that typically occurs in the lymph nodes of your body. And both my father and brother were cured by modern day medicine. Both of them received chemotherapy and radiation, but it had a very large impact on me. And from a young age, I knew that I wanted to be involved in medicine. And I thought at the time, cancer oncology space. I came from a very blue collar family. I was first generation college student. So I didn't necessarily have the tools to navigate the path, which can be pretty complicated. Thankfully, I started at a young age volunteering with a group called Camp Good Days and Special Times, which is in Buffalo, where I grew up. We worked with cancer patients, their siblings, and their family members. And that allowed me to interface with patients and also with their doctors, and sort of carried my ambition on into undergrad when I decided at that point I would go to graduate school of some sort. And I thought it was medical school, but my first zigzag was I decided to go to dental school because I was nervous about medical school. It's a very large commitment and it's a big sacrifice lifestyle-wise for many, many years. So I went to dental school for a semester, realized that was not my path, and within one semester left or dropped out, I guess, of dental school, despite people saying, "Oh, that will look terrible on your application," but it didn't. I explained my story to the medical school admission officers, and I was thankfully accepted. And once in medical school, I knew I would do oncology in some capacity. So it was about second or third year of medical school that we were gearing up to apply to residency. And I, at that time, thought I wanted to do surgical oncology and be in the operating room. And I had an interest in GYN, female malignancies. I think that patient population is very rewarding to work with, and the surgeries are quite complicated. So I applied into OBGYN, and I was up in Boston at Brigham MGH. And that was my next zigzag, because I realized within that interim year that I didn't love being in the operating room as much as I thought I might, which in surgery, you need to love it because you might be there day and night, many days of the week. But during that time, I was able to be exposed to radiation oncology, which is a small niche field that even in medical school, you get practically no exposure unless you actively seek it out. And many doctors who graduate medical school and residency have no clue what radiation oncologists do. But thankfully, I was able to sort of interface with them during intern year, and I decided I'm going to apply into radiation oncology residency. Again, it was a risk. People said that might not be looked upon, very well, but it worked out. And I went to Duke for my residency in radiation oncology. And the reason I ultimately chose radiation is multifaceted. It combines all the things I really love about medicine. So it's not radiology. So I'll sort of clear there. Radiology would be someone that's reading films, writing reports in a room. Radiation oncology is very clinic based and patient facing. So I see patients every day of the week, and I have very intense relationships with patients, and I meet with them, consult, I give advice and opinion on how we should treat them. And then I use a lot of technology, CT, MRI, PET, in order to create a plan of radiation where I draw on like every single slice of a scan. I draw what we're treating, where we're treating, create the plan with the help of many people, physicists, dosimetrists, all these sorts of people that help with the technical aspect. And then we treat the patient. And so it really combines oncology, medicine, patient interaction, but also it has a lot of almost an artistic component where every case is different. Every case is planned by hand. So I get my sort of surgical brain working by doing that. But I'm not in the OR, which like I said, I don't love. So that's how I ended up in radiation oncology. And my first job as an attending was out in DC in a private practice. And I eventually made my way, though, to Stanford, where I've been for the last 4 years at this point.
So thank you for sharing that, and also diving a little bit deeper into like what it actually looks like day in and day out. I know I've had the the pleasure of being on a call with you while you are running back and forth and talking with patients. So also another reason that I want to say thank you for taking the time to be here today. And I think I remember when we chatted, you had said a little bit that you had taken some time off prior to going into medical school. So I would love to hear how that period kind of influenced your career path and what that meant for you, how impactful that was for you.
Yeah, I was in undergrad, and then I went to dental school, and that was sort of right after undergrad, but then I decided dental school was clearly the wrong decision. And so I took probably about 2 years off before going to medical school. And during that time, I actually worked with a radiation oncologist. I shadowed them. I helped with a research project. I did other volunteer work with Camp Good Days again, and I was getting back involved with those groups just to sort of solidify, what I wanted to do and which patient population and what capacity, where I wanted to end up. And, I think it's important to realize that not everything's a rush. You don't need to go from undergrad to med school to residency, and that things change, evolve, you learn more about different professions, and it's okay to take time to sort of reevaluate, and it's okay to sort of toss one plan away and switch gears. I mean, there's never a wrong time to do that. If you think it's the right decision, you take that leap of faith, and if it's for the right reason, you're probably going to land.
Mm-hmm. Yeah, thanks for sharing that. And then, so I kind of want to go back to what you were saying in terms of like how you described a little bit of the artistic element in the work that you do. And I think like from a kind of figuring out like what the best care plan is one component of it. And then also like wanting to bring in this aspect of like not every case is the same, and how do you meet your patients that may have different identities, and how does that get incorporated into their care plan is my first question. There's many others that follow that, but like how do you do that?
Yeah, so I mean, so for face value, every plan is different in the sense that anatomically, physiologically, everyone's body is incredibly different. Every tumor is different. And so the plans on a technical level are never the same and always involve unique differences from start to finish. From a patient perspective, are you referring to sort of, LGBTQ and, sort of BIPOC and that sort of?
Yeah.
Okay. So, from that perspective, it gets much more interesting, right? So all of our patients that we meet with diverse backgrounds bring their own sort of perceptions, expectations, and experiences with healthcare. And at my initial location with Stanford at Pleasanton, I had a very sort of not a very diverse population, but in Castro Valley in the East Bay, a much more diverse population, socioeconomically, racially, LGBTQ patients. And I try to first just assess where a patient's coming from and really just try to understand what their experiences are, what their understanding is of why they're sitting in the room with me, and try to sort of smooth out any of those fears or doubts. I think that's the, in my world, it's such a technical job what I do, but it's also incredibly a lot of soft skills that go into it and sort of teasing those things apart and being, holistic in my approach. A lot of patients have had injustice in healthcare, have had, there's been a lot of, inequities in healthcare, and whether a patient admits that or not, it still comes with them when you meet them during the discussion of treatment. So I try to understand those things, and then I try to be receptive to everything and know that I don't actually know everything, and understand that I don't understand what everyone's background is. But if you're willing to learn and listen, that goes a long way. Those sort of acts right there make a huge difference in patient outcomes. You can have the best plan, the best radiation, oncology, and chemotherapy, but if you don't understand what those challenges are for a patient, one patient can do terrible and we could fail them, and another patient, we could help them succeed. And they just make such a dramatic difference. Thankfully, I have such a great staff at my office that helps me with these things, along with therapists, social work, and all sorts of ancillary support services that are incredibly important in oncology to sort of support our patients holistically.
Awesome. Thank you. And then I guess I had another question in terms of like those skills of that you've developed, and just the way that you meet your patients when they come into your office or are in their care is in your hands, right? Like, how do you think that you've obtained those skills? Like, do you feel like that was incorporated through your like academic curriculum, or was it something that you felt like you had to kind of learn on your own? And how, yeah, either one, how did that go? Mm-hmm.
No, it's a great question. I think right now, thankfully, in medicine, there's a shift to have more patient-centric care and to sort of understand those inequalities, disparities, and how to sort of broach those conversations. And where I trained at Duke for med school and residency, there was a very large emphasis on that. And we spent every week from year one in med school in a course that was a sort of a patient interaction course. We had actors that came in and presented us with every sort of patient, sort of problem that you can think of, every curveball. And we would have to sit in front of our colleagues, our classmates, and navigate those conversations. So that definitely made a huge difference, but it was sort of just scratching the surface. It sort of just gave you the basic tools and essentials of how to navigate conversations. It didn't delve into, the true sort of inequality disparities that many different groups have, because I mean, that's impossible. There's just so much to learn and know. And that's where it becomes important to just be receptive and open and admitting when you are not as knowledgeable. I think the biggest gap in medical training right now has to do with sort of sexual function, sexual impact, um, sort of gender reassignment, all these sort of things that the training is lacking. And there is a huge interface in cancer, especially when you're treating prostate cancer, GYN cancers. Um, there is a definite dearth of sort of education and preparation for that. And our patients, it impacts them. They might not be thinking about these things when they first meet you. They might not be thinking about it during the treatment, but I guarantee you months later, years later, they will be thinking about it because it changes their whole lifestyle. And so I try to make it a point to open all these conversations in the beginning. I find that eventually will allow a patient to get comfortable enough, whether it might be months later or it might be a year or two later, but be comfortable enough to sort of tell me what's going on, besides just the cancer.
Yeah, that's a really good point. And I'm kind of going rogue with this conversation. I did a lot of work in breast cancer, and it one of the things that I'm not sure if you're probably familiar with San Antonio Breast Cancer Symposium that happens in Texas each year. But I remember very vividly from my time there, I think before the pandemic, so 2019, December 2019, and one of the researchers had kind of gotten on stage and was like, well, like just saying just cut the breast off, and all of the advocates are in uproar, obviously, because like what that means to someone's like sexual identity, how they navigate through their own personal intimate relationships. And it was a very interesting dialogue to like witness in terms of, and I don't think that it's hard to come. I don't want to say that it's hard to come to those things, but it's more like the learning and training of like, looking at patients as whole beings from like a very holistic space, as opposed to, yeah, we're just going to cut off the breast and that will solve all of the things. So, how do you feel that like folks that are kind of navigating like a potential career in this in the way that you are can kind of have exposure to some of those experiences um, through like volunteering, or is it just like you do it as you learn?
Yeah, well, I'll go back to sort of what you said, because I thought it was interesting, just the comment about, at the symposium, because I think it is a very common sort of perception of doctors and oncologists, especially, where, is where it's like, the job is to cure the tumor, get rid of the tumor. And if you got rid of the tumor and they're alive, then you succeeded. But we forget that, again, months later, years later, these things have mental impacts. And I've seen it in many patients, whether it's from mastectomies, like you mentioned, or men having prostate cancer and then have no erectile function, or a woman having a GYN tumor and no longer has good vaginal function. I mean, it's endless. The list is endless. And, many people just don't think about it. But we're trying to improve on that. I'm involved in some work, and potentially we're looking at starting a new sort of a research trial that kind of addresses what you were talking about mastectomy. Currently, a lot of our patients get mastectomies, and if they require radiation, they don't end up getting reconstructed for many, 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 many months afterwards. And so I'm working with one of our surgeons at Stanford, and we're putting this study together to see if we could do the radiation followed by more immediate reconstruction within a few weeks, which would, I think take a lot of the mental impact out of the equation of a woman who's gone for months of chemo and now surgery and radiation to at least have reconstructed breast, instead of waiting, another 6, 7, 8 months to have that. So that's just kind of my soapbox, and I completely agree. And now your other question was, oh yes, experience. So, it's funny. Before I became a doctor, all through undergrad, actually high school, undergrad, and up to med school, I was a waiter. And I really do think that my ability to talk to patients and understand patients is mostly attributed to me being a waiter for like over 10 years. And it's just because it's just you learn soft skills, communication skills, people skills, puts you in a lot of different situations. So that really helped me. And then these other conversations you sort of pick up along the way, shadowing, volunteering, sometimes, but the learning how to navigate the truly difficult ones, I think I that became most clear to me after working with specific doctors who were just phenomenal at it. And I can go back throughout my training in my mind and I can just name them, this one, that one. And there's probably about 5 or 6 in my training that truly I looked at them and I said, I want to be like you, the way you describe things, the way you listen to your patients, the way that patients feel when they leave the room. And so it's important just to find those people that you can role model and that you think, would be an exemplary of what you want to be, and sort of then take those pieces and build your own style along the way.
Yeah. Awesome. And then I know you talked a little bit about like some of the care team and bringing this together, because I know you also mentioned like the long-term mental and emotional impacts that I think don't get talked about a lot, when it is just like, we're going to treat, but not look at like the long-term care continuum and what might come along with it. And so I know you mentioned a little bit of, you have other staff that you work with, like social workers, et cetera, and how they kind of come into play. But I wanted to know a little bit more about your experience, like working in that integrative setting, and how that has been for you.
Yeah, I think it's so important. I initially, when I left training, I was in a private practice outside of DC, and it was phenomenal. One of the best practices, amazing physicians that work at the practice. But it was not an academic center. So I sort of got both sides of the coin, seeing private practice versus a large academic center. And it makes a huge difference when you have every single resource at your fingertips working together. At Stanford, we have everything, from your doctor to the nurses to the front staff, who are just as important from, beginning to end, can shape a patient's experience. Walking in the door, just their mental state, how they're addressed can shape their experience. And then add on things like social work to help navigate the complex socioeconomic issues. We have therapists that focus on sexual function. So patients that have prostate cancer, GYN cancer, that have these impacts, we can send them to this therapist to help sort of work through. We have support groups where we can bring patients together, because some patients like to hear it from another patient versus from a doctor who never had the diagnosis. We have integrative medicine, things like acupuncture that works. I have patients that use acupuncture all the time for all sorts of issues, and it works. There is certainly a place for Eastern medicine in our care, and you need to be able to talk about that with patients and try to guide them, and we have those resources. So all of those things, really, and palliative care, I didn't mention that, but so important. Palliative care, they're doctors that are sort of symptom management. They help with issues like pain, weight loss, appetite, all sorts of problems that our patients encounter. And there was actually a study that was published that showed for patients who have metastatic cancer, if they're referred early on to palliative care, they live longer than patients who are not. So this isn't even treatments. This is just supportive care, sort of helping in all those domains. Those patients do better. And we need to do a better job of assessing these things. You look at all the studies that have been published for years and years, and again, it's always overall survival, progression-free survival, tumor control. And we're starting to get more depth and more breadth of data in these studies when it comes to patient-reported outcomes, thankfully. But it's a pretty new sort of shift. Patient-reported outcomes were not something that we recorded for a long time. So I'm definitely happy to see that, because it gives us a better sense of, okay, we're doing a good job, but what are the repercussions long term from these treatments?
Mm-hmm. Mm-hmm. And I like how you mentioned like the also like measuring the quality of life as well that comes along with like, okay, we've reduced the tumor size, we've gotten rid of it, but like, how is your life? Is it okay? Like in all of these other aspects. So thank you for sharing that. I also wanted to, I don't know, I mean, other people probably don't know this. I know this, but you did some lobbying and advocacy work as well. And I know that's something that's of interest with a lot of the cancer leaders like us community, is like, if I'm going into this field where I am like working directly with patients, like where and how is there room or even capacity to work at the intersect of advocacy and making kind of more of a system level change. So I'd love for you to share a little bit about some of that work that you've done and how you found a way to incorporate it into your practice.
Yeah, absolutely. I did a lot of advocacy work all through medical school. Over at Duke, I was involved in, we have a gay straight alliance, or at least we had it, I haven't checked back in years. But I was very involved with the Gay Straight Alliance, and we did a lot of education and fundraising. We made pins that we handed out to everyone in the hospital to wear, to create awareness and safe spaces for people. We would, nominate yearly different physicians that we felt were really upholding the sort of values that we wanted. So that was a big part of me throughout medical school, and into residency as well. I did additional work such as that. During residency, I was able to do a hospital administration fellowship. So very amazing opportunity at Duke. As a radiation oncology resident, you get 1 year of research. Residency is a total of intern year plus 4, so 1 year of research. And my faculty at Duke actually let me do this fellowship instead with the CEO of Duke Hospital. And it was one of the best experiences ever. The CEO of Duke Hospital is just phenomenal, brilliant. His name is Kevin Sowers. He's over at Hopkins now. And together we did a lot of lobbying in DC, and we actually went to DC, met with senators, and we were lobbying for 340B, which is a drug pricing program. It essentially allows different hospital entities to sort of stretch the federal resources further. Big pharma doesn't like it because they don't make as much money, but obviously it's important, especially in places where academic centers like Duke are using this to sort of try to give back to the community that doesn't have the resources. And so Kevin Sowers and Duke are very big proponents and have been for years, and are on Capitol Hill every year. So I was able to be there and working in that capacity, which was amazing. And now at Stanford, I have a role sort of where I'm one of the lead LGBT mentors and sort of assigned for the radiation oncology department. I also have done different programs where we work with residents in sort of leadership and diversity, and I help mentor them, and they sort of work towards a larger project presentation at the end of the year. So there's always room for it. You really, if you have an interest, you really just got to chase it, and just, if you find someone to help support you, that's the best way. And I'm a great example for that, because for radiation oncology, majority of people in my field are heavy researchers, whether that's basic science or if it's sort of clinical based research. But it's a lot of research, a lot of publishing, which is needed. That's how we advance the field. But I have a lot of other interests, namely in diversity and in this space. And I've been able to sort of carve that niche out, and I've gotten a lot of support in every place that I've been, both Duke and at Stanford. So I think if it's something that means a lot to you, there's definitely a place for you.
Thanks for that. I feel like that is very reaffirming to hear, because I know a lot of the emerging leaders that I speak to, they're like, well, I want to do that, but I don't know if there's room and space. And so that's good to know. I wanted to ask you about a little bit how that's been in terms of when you were lobbying for, I can't remember the name of the bill, but you had mentioned that, it was not something that like industry pharma like was a proponent of. So how do you like kind of navigate that nuance of like, I feel like there's a lot of, I don't know. There's a lot of work that when it comes into the advocacy space of like you might be opposing industry, but like this is also an industry that is producing treatments for people that we are supposed to be advancing their health and supporting them. So like how I don't know if you have any thoughts or
Yeah.
sentiments about that.
Well, it's, the program, again, it's called 340B. Don't have to remember that though, but it's essentially like a drug pricing program that's been around for years. And what it does is it allows hospitals and clinics that meet certain qualifying factors to treat low income and uninsured patients who can buy prescription drugs at a discounted price up to like 50%. And so that's why pharma, they lose money because the drugs are getting discounted. But when you look at the revenue from these big pharma companies, they're not hurting. And, I think most people in politics, even if they're not well versed in medicine and healthcare, know that these companies are not, hurting and that they have pretty big margins. And so it doesn't, and again, I was, a company with Kevin Sowers who's been doing this for years, but sort of giving the facts as it is. These are the margins versus these are patients who can't afford it. These are patients who would be left without appropriate treatment. And, once the senators hear, oh, wow, my constituents, this huge base of patients that, I'm supposed to be here supporting, I think most people, who are in it for the right reason, agree that these programs need to exist, and that we need these programs to help make sure that everyone has a fair and equal chance to, access to treatments.
Thank you for sharing that. And yeah, I know that was a little rogue, but I was just
Oh, no, yeah.
curious to know how like the nuances of that and how you've experienced them. And okay, I have one more question and then I will open it up to other folks so that they can have the opportunity to connect with you as well. But I know you mentioned like kind of throughout your giving your responses about some of the connections that you've made. And so I just wanted to kind of pick your brain a little bit about like how you were able to like establish like mentorship or these different connections with some of the folks that have inspired you to kind of implement these values within your practice.
Absolutely. I think it's the most important part of succeeding in any career is networking and finding mentors that can help you, help guide you. They can sometimes open doors for you, and it really makes a big difference. When it comes to how to find them, I think the best way, although sometimes not the easiest way, is to just be a big proponent and advocate for what you stand for. For me, it was from a young age, LGBTQ. I came out at a very young age when I was a teenager, and that was challenging and difficult. But by volunteering, working with advocacy groups, having it on my CV, writing about it in essays, interviewing and talking about it, eventually here and there, you meet people that said, oh, hey, I do similar work, or, oh, hey, I identify in a similar capacity. And that's a great way to sort of build those connections. So this has helped me, going into medical school, getting my job. These sort of connections have helped in all these different capacities. And it's important, once you meet that person and you sort of make that relationship, to just try to maintain it. it doesn't have to be the most deep relationship, right? A lot of these people that I've met have been in passing at an interview, at a conference, but it's, let's just switch information. And then maybe every 6 months, 7 months, I would send a message, I would check in, I would say, hi, I just want to let you know this is how I'm doing. I'm still thinking I want to do XYZ with my career. Do you have any advice? How have you navigated this? And that's really, it's made a huge difference in everything. So, not easy to sort of find those people, but once you do, just work on, maintaining and building a relationship.
Thank you for that. Okay, I will open it up to folks that have come to this event today. So you can feel free to come off camera and ask a question, or if you would like to just ask in the chat, or you can also like share any sentiments if anything resonated with you throughout our conversation that you'd like to share. I will open up this space to do that.
I would love to ask a question. I've kind of been dying this whole time to ask a question. So first let me introduce myself. My name is Alyssa. I am currently an MS4 who's actually finishing in about 2.5 weeks. I'm at Duke and I'm doing Rad-Onc right now. So I just wanted to shout out to Rad-Onc at Duke. So I have been really trying to emphasize as much as possible, like onc exposure in med school, which we don't get a lot of. And one of the things that I have been wondering sort of throughout my clinical experiences is if there are people who are looking at the additional sort of gender dysphoria experienced by trans individuals who are receiving care for reproductive cancers. And I've heard a little bit about sort of the, dysphoric experience with like cervical cancer screening in trans men, or, considering like a new diagnosis of prostate cancer in a woman, trans woman. And so I've kind of tried to talk to some of my attendings about this. And generally the answer that I get is, no, 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 it hasn't come up. And I'm not particularly satisfied with that answer, because in some ways, like, we all know that trans people have existed for a very long time. And so it has come up, you just might not be aware of it, because that person might not have felt safe speaking with you about it. And so this is a very long-winded question, but I'm wondering sort of if you have advice or recommendations for people like myself who are currently training on how to create a safe space specifically in the scenario of someone who is transitioning or has transitioned and is now experiencing a reproductive cancer that might be really messing with their mind around them.
Yeah, that is a very good question. And it's the sad truth is that there is really a lack of support and resources and of training for these patients. I think in your situation, I think doing things like creating a safe space visually for patients, and I know you're probably already aware of this, but wearing a pin, doing something that sort of says, I see you or accept you. I think that's sort of a big first step. And the next thing is sort of, trying to approach patients and, understand what pronouns do they use, how do they identify as themselves, how do they identify, because this is also not something that's usually addressed. And even if patients do put what they prefer as their identification in the medical record, a lot of times people don't even acknowledge it, and they'll use their sort of legal name, And again, it's a constant education process. It's a creating safe space for patients. It's educating your colleagues. If you notice that your colleagues are not using the pronouns that a patient might want, addressing, the fact that there might be implications of the treatment. It's sort of educating them and saying, hey, listen, this patient identifies as a trans, male, trans female, and sort of talking through what that means. it can be difficult, those conversations, especially when you're in medical school training. It's difficult to sort of have a voice, but I encourage you to find your voice and just be an advocate as much as you can be. Um, you're going to encounter challenging situations. You're going to encounter people that don't and again, we shouldn't expect people to understand everything and know all of the intricacies, but we should expect our healthcare providers to be receptive, admit their lack of knowledge, and try to understand what that patient's barriers are and what their background is. And I think it's always, I love when people are vocal and advocates for that. I think it's huge for our patients. And yay for Duke. I hope are you loving your radiation oncology rotation? Is it going well?
I am. It's wonderful. I'm on my second week. Everyone is welcoming and incredible and brilliant. And yeah, it's been really great.
Oh, that's so good to hear. Send my regards.
Okay. Anyone else? Okay, Amy.
Hello.
Hi.
I am Amy. Sorry, there's always a delay when I go off the mute, so I was waiting for that to happen, thus the pause. I am the executive director of the Women's Cancer Resource in Berkeley. We serve Alameda and Contra Costa County folks. And we primarily serve low-income people of color. We also have a long history of supporting LGBTQ plus community members. And so we do patient navigation. We're navigating a lot of our patients to treatment places, meetings with doctors, translation, all of that stuff. I think my curiosity and my question is, from the community partner lens, sitting in the space that you're at, how can we work better with our medical? I mean, we're systems people, right? We're not just serving clients, but we're sitting on, anti-racism cabs at Highland Hospital. We're on Stanford and UCSF cabs, really trying to bring in the patient voice, our client's voice. And so how do you see that we might be able to better partner with our medical systems to advance this work and to really create a space of inclusion, given the landscape of where we are and the expertise that we have in, working directly with patients? What would a partnership with the hospitals look like?
Yeah, that's a great question, Amy. Thanks, and nice to meet you. So I think something work that I've done relatively recently this last year, and you might be familiar with Dr. Dolezal. She's a medical oncologist. She is up in the Emeryville area. But we work with women with a history of GYN, breast cancer, and we put on a symposium where we invite sort of multiple different patients to tell their story, and the physicians are sort of in the background in order to field questions and help navigate when a patient is explaining where the barriers existed, what made the journey difficult. We then sort of can pipe in and give some advice, and also it gives us an opportunity to learn, what are we missing? How are we not supporting the patients? And so we just had one of those, I want to say about 6 months ago, and it was wonderful and very successful. And like I said, that was primarily breast GYN. I think those sort of platforms I find the most helpful to really integrate the patient voice, because it really brings together doctors from many different backgrounds, patients who are under treatment, patients who are years out of treatment and survivorship programs. And it really brings some clarity to sort of where the pitfalls are and how we can be better. That would probably be the one thing that would come to my mind.
That's great feedback and insight. Thank you.
And I'm always happy if you're ever interested in doing something like that. I'm happy to be involved with it or be a moderator or sort of a guest speaker to help with, questions or anything like that.
Wonderful. Thank you.
Of course.
Okay, I also see Mike has their hand up.
Hi, thanks. Yeah, I work for a large biopharma company in development, specifically within precision medicine regulatory affairs. I'm kind of curious how you handle getting patients that may not fit into stereotypical categories into like clinical research, because so often I'll see things may be very rigid as far as gender specifics in order to qualify, or even just language such as women of childbearing age, or language. There is a lot of initiative to have more inclusive language, but I'm kind of curious from your perspective, if you're an investigator for any clinical trials, of how do you help broaden access to those people that might get missed because of the specifics in a clinical study protocol?
Absolutely. Thanks, Mike. Yeah, that's a great question. It is a huge problem and deficit in the current sort of research and trials. It's the language that can be restrictive, and it's also where these trials are being, where they're being sort of recruiting patients. If it's at an academic center, if it's in an affluent area, you'll look at these trials and you'll see predominantly white male sort of participants. And then it doesn't really allow for that research to be generalized to other people in society. So it's definitely a very big problem that again is something they're trying to start to tackle. At Stanford, I think one of the ways that we're trying to sort of decrease or sort of make things with a more sort of equitable inclusion is by our satellites. So I mentioned I'm out in Castro Valley. We have satellites in Turlock, San Jose, Pleasanton, and the patient population is much more diverse in some of these areas, especially in my clinic. By Stanford going into a lot of these joint ventures, in Castro Valley, it's with Sutter Hospital, and that's a very, very big joint venture that we just established, and it's going great. There's another one in Turlock. By doing these joint ventures, it's allowing the academic center, which was very siloed for a long time, in this case in Palo Alto, to increase its reach and accessibility to patients with diverse backgrounds who might not live in that immediate area. So I think that's one of the really exciting things about our joint venture, and many academic centers. Duke is doing something very similar. When I was at Duke, we were starting to integrate many other sites across the state, and it eventually, as these research programs become more robust, I think it's going to start making for a more diverse profile of enrollment in these trials, because it's incredibly important.
Thanks. Yeah. And I mean, certainly we see that FDA is very keen on that with diversity plans, the expectation for new clinical trials, et cetera. And I think on the surface, a lot of people, see that and they think, racial diversity, off the top of their head. But, it also means if it's a PrEP, treatment, that there are trans folks that are included and represented, so that they're on that indication statement. It's not, oh yeah, this was tested just in cis white gay men, and we think it'll work for this other population as well, but to actually have data is really so important.
Yeah, I agree. And it's about, sort of expanding those inclusion in that language, and expanding it, and also making it more granular so that the results can be teased apart and we can sort of see those differences. I completely agree.
Thanks.
Of course.
Great question. Okay, we have time for one more. Harold.
Hello. Hello, you guys. Thank you so much. Everyone, I am Harold Abrams. My pronouns are he, him, and I'm also a project manager at the Cancer Network. And I really want to hop on here and just thank Dr. Martella for joining us again. I had the pleasure to interview Dr. Martella for another project we have at the Cancer Network called Frankly. It's our Sex After Cancer microsite. And you talked about it tonight about that kind of importance of, we're treating cancer like for the physical part of it, but there's so much many implications mentally with that, and how we really want doctors to consider that, especially for LGBTQ plus folks. Our sexuality has a certain meaning for us, and so really appreciate that. And thanks for coming out tonight. I really appreciated your origin story. There is no straight path to, how you get there. You never know. And I loved hearing how even your experiences as a waiter, there was some value there that you pull into every now and then. So, but again, thank you so much for coming out tonight. And thank you, Jayla.
Thanks, Harold. I appreciate that, and appreciate doing our interview initially and helping me, become involved. I think that, this organization is doing some wonderful things, and it's so important to talk about these and have these conversations so that we can get a better understanding of, how we can do better.
No, thank you everyone for asking amazing questions. I think, this is also a space for you all to connect as well. So Dr. Martell, if you feel so compelled, you can share your information with anyone you'd like to connect with. That's what this space is for. I'm gonna transition and give a few more updates for Clue, and then I will let you all enjoy the rest of your evening. But we have a few things coming up. So we have a Cancer Career Summit, which is going to be a two-part series. It'll be a cancer or career readiness workshop, which will take place on May 23rd, and then a career fair that'll take place on June 6th. The readiness workshop is kind of like tee people up, get them ready for the career fair. It's going to be open to any and everyone that is like either, entry level, looking for transition, looking for new opportunity, looking to connect with other people. That's what this space is for. And so if you would like to, I think, let's see, we'll drop the link to this in chat. And then the next thing that we have that's coming up, whether it's relevant to you all or anyone else in your network, is each semester we do host a health disparities paper and poster contest. Austin Waters and Sydney Wilcoxon are our two winners from the winter series, and they just did some amazing work. All we ask is that for people to submit things that they've already worked on so that we can uplift them. I think there's a lot of wonderful things that our emerging leaders are working on that don't make it out of the academic space all the time. And so you could find their submissions on our resource library. And then we did also open our submissions for our next iteration of this, and those are going to be due on May 31st. So if you know anyone that is a student or working on some project that deserves to be acknowledged for the work that they're doing, this is the space for that. But all of that to say, I wanted to thank everyone for coming to this program today. This was super exciting. Please connect with folks that you feel like it's relevant for you to connect to. If you have any questions, want me to make any personal introductions, my email address is on this slide. Feel free to reach out. But all of that to say, thank you everyone for showing up today. It was a pleasure holding this space with you all, and have a good night.
Thank you, Jayla.
Yeah.
I dropped my email, by the way, in that chat if anyone has questions. Martella at Stanford.
Perfect. Thank you.
Welcome.
Thank you.
Thank you.
Thanks.